Welcome everybody. Today's lecture will be on infertility. What's the definition of infertility? It's failure of conception after at least 12 months of regular and protected intercourse. The chance of a normal couple conceiving is estimated to be 20 to 25% per month, 75% by 6 months, and 90% at 1 year. Epidemiology. Up to 50% of infertility is due to male factors. Up to 25% of couples may be affected at same point in their reproductive years. Pathophysiology. Failure of fertilization of the normal ovum due to defective sperm development function or inadequate numbers. There may be abnormalities of morphology, we call it teratospermia, motility, asthenospermia, low sperm numbers, oligospermia, or absent sperm, azoospermia. Abnormal epididymal function may result in defective spermatozoa maturation or transport or induce cell death. Etiology. Idiopathic in 25% of cases. Varicocele represents about 40% of cases. Cryptorchidism, undescended testis, functional sperm disorders, immunological infertility and sperm antibody production, head or tail defects, Cartagner syndrome, immotile cilia, dyskinetic cilia syndrome, erectile or ejaculatory problems, testicular injury, orchitis, postpubertal, bilateral mumps, orchitis, testicular torsion, trauma, radiotherapy. We'll continue the etiology. Endocrine disorders like in Kalman syndrome, isolated gonadotropin deficiency causing hypogonadism. Prader-Willi syndrome, hypogonadism, short stature, hyperphagia, and obesity. Pituitary gland adenomas, radiation or infection. Hormone excess like in excess prolactin, pituitary tumor, excess androgen, which occurs in adrenal tumor, congenital adrenal hyperplasia, anabolic steroid use, and excess estrogens. Genetic disorders like Klinefelter syndrome, when there is an extra X chromosome, 47XXY, and this involves azoospermia, defect in FSH-LH secretion, and a decrease in testosterone. Male genital tract obstruction, like in congenital absence of the vas deferens, epididymal obstruction or infection, Mullerian prostatic cysts, groin or scrotal surgery. Systemic disease include renal failure, liver cirrhosis, cystic fibrosis. Drugs, chemotherapy, alcohol, marijuana, sulfasalazine, and smoking also contribute to the etiology. Environmental factors, pesticides, heavy metals, hot baths. Well, let's come to the history. Sexual history includes duration of the problem, frequency and timing of intercourse, previous successful conceptions, previous birth control, erectile or ejaculatory dysfunction, developmental, including the age at puberty, history of cryptorchidism and gynecomastia, medical and surgical history, detailed assessment for risk factors, recent febrile illness, postpubertal mumps, orchitis, varicocele, testicular torsion, trauma or tumors, sexually transmitted diseases, genitourinary surgery, radiotherapy, respiratory diseases associated with ciliary dysfunction, and diabetes all should be acquired within the history. Drugs and environmental. Previous chemotherapy exposure to substances which impair spermatogenesis or erectile dysfunction, alcohol consumption, smoking habits, hot baths. Family history should be on hypogonadism and cryptorchidism. Examination. Perform a full assessment of all systems with attention to general appearance, evidence of secondary sexual development, signs of hypogonadism and gynecomastia. Urogenital examination should include assessment of the penis for Peyronie's plaques, phimosis, or hypospadias. Measurement of testicular consistency, tenderness, and volume should be done. and we do it with Prader orchidometer to assess the volume. Normally it is more than 20 ml. Varies with race. Palpate the epididymis for tenderness and swelling, and spermatic cord for the presence of the vas, and we should examine for varicocele. Digital rectal examination should be done to assess the prostate. The schedule here shows the comparison of the updated WHO 2010 recommendation for the normal seminal fluid analysis. The volume should be more than 1.5 ml. The pH should be more than 7.2. Sperm concentration should be more than 15 million spermatozoa per ml and more than 39 million spermatozoa per ejaculate. Motility in general should be more than 40%, but progressive motility should be more than 32%. Morphology should be more than 4%, and the vitality should be more than 58%. White blood cells can be present and should be less than 1 million per ml. Other parameters also are shown. Investigation of male infertility. Special investigations. Chromosome analysis indicated for clinical suspicion of an abnormality, azoospermia or oligospermia, small atrophic testis with an increase in FSH. Testicular biopsy is performed for azoospermic patient to differentiate between idiopathic and obstructive causes. It may also be used for sperm retrieval. Sperm function tests. Postcoital test. Cervical mucus is taken just before ovulation and within 8 hours of intercourse, and microscopy is performed. Normal result shows more than 10 sperms per high power field, the majority demonstrating progressive motility. Abnormal results indicate inappropriate timing of the test, cervical mucus anti-sperm antibodies, abnormal semen, and inappropriately performed coitus. Sperm penetration test. A sample of semen is placed directly onto pre-ovulatory cervical mucus on a slide, and the penetrative ability of the spermatozoa is observed. Sperm cervical mucus test. A sample of semen, the control, and one mixed with cervical mucus are placed separately on a slide and observed for 30 minutes, more than 25% exhibiting jerking movements in a mixed sample, but not the control. And this is a positive test for anti-sperm antibodies. Treatment options for male factor infertility. General. Modification of lifestyle factors. Reduction of alcohol consumption. Avoid hot baths. Medical treatment. Correct any reversible causative factors. Treatment options for male factor infertility. Hormonal. Secondary hypogonadism, pituitary intact, may respond to human chorionic gonadotropins, HCG, 2000 international units subcutaneously 3 times a week, which stimulates an increase in testosterone testicular size. If the patient remains azoospermic after 6 months of treatment, FSH is added, human recombinant FSH, or human menopausal gonadotropins. Alternatively, pulsatile LH-RH can be administered subcutaneously via a mini pump. Testosterone deficiency requires testosterone replacement therapy. Hyperprolactinemia is treated with dopamine agonists like bromocriptine. Anti-estrogens, clomiphene citrate 25 mg, are often used empirically to increase LH-RH, which stimulates endogenous gonadotropin secretion. Erectile and ejaculatory dysfunction. Erectile dysfunction may be treated conventionally, like with oral intraurethral intracavernosal drugs, vacuum devices, or prostheses. Ejaculatory failure may respond to sympathomimetic drugs, like disipramine or electroejaculation used in spinal cord injury, where an electrical stimulus is delivered via a rectal probe to the postganglionic sympathetic nerves, that innervate the prostate and the seminal vesicle. Anti-sperm antibodies. Corticosteroids have been used, but assisted conception methods are usually required. Treatment options for male factor infertility. Surgical treatment for the genital tract obstruction. Epididymal obstruction can be overcome by microsurgical anastomosis between the epididymal tube and the vas. We call it epididymal vasovasostomy. Vas deferens obstruction is treated by microsurgical reanastomosis of the ends of the vas and is used for vasectomy reversal. Ejaculatory duct obstruction requires transurethral resection of the ducts. We use this by scope. Varicocele is repaired by embolization or open or laparoscopic surgical ligation. The pictures here enlights the microsurgical operation of epididymal vasovasostomy. On the right, we can also see the transurethral resection of the ejaculatory duct. Assisted reproductive techniques. Sperm extraction is used for obstructive azoospermia. Sperms are removed directly from the epididymis by microsurgical epididymal sperm aspiration or by percutaneous retrieval. If these methods fail, testicular sperm extraction or aspiration may be tried. Sperm undergo cryopreservation until required. Later on, they are separated from seminal fluid by dilution and centrifugation methods, with further selection of the motile sperm and normal forms. Assisted conception. Intrauterine insemination, IUI. Following ovarian stimulation, sperm are placed directly into the uterus. IVF, in vitro fertilization. Controlled ovarian stimulation procedures, oocyte, which are then retrieved under transvaginal ultrasound guidance. Oocyte and sperm are placed in petri dish for fertilization to occur. Embryos are transferred to the uterine cavity. Pregnancy rate are 20 to 30% per cycle. Gamete intrafallopian transfer. Oocyte and sperms are mixed and deposited into the fallopian tubes via laparoscope. Variations include zygote intrafallopian transfer and tubal embryo transfer. Intracytoplasmic sperm injection, ICSI. A single spermatozoon is injected directly into the oocyte cytoplasm through the intact zona pellucida. Pregnancy rate are 15 to 22 per cycle. This is the highlight of intracytoplasmic sperm injection steps. Also, to clarify the GIFT procedure, which is gamete intrafallopian transfer. This is a modified version of in vitro fertilization. Well, unlike IVF, when embryos are observed and raised in the laboratory for 3 to 5 days and then transferred to the intrauterine position, the GIFT procedure is transferring sperm and eggs just mixed together before being inserted, and with a luck, one of the eggs will become fertilized inside the fallopian tubes. Disorders of erectile function, impotence. Let's come to define ED. Impotence or erectile dysfunction is persistent inability to achieve or maintain a penile erection sufficient for sexual intercourse. Epidemiology. Moderate to severe ED is found in about 10% of men aged 40 to 70 years. Prevalence increases with age. Etiology. ED is generally divided into psychogenic and organic causes, although it is often multifactorial. How can we evaluate impotence? Well, we start with history. Sexual history. Onset of the ED. Sudden or gradual. Duration of the problem. Presence of erections. Nocturnal, early morning, spontaneous. Ability to maintain erection. Early collapse, not fully rigid. Loss of libido. Relationship issues. Frequency of intercourse and sexual desire. Relationship problems. All these should be required. Medical and surgical history, including hypertension, cardiac disease, peripheral vascular disease, diabetes mellitus, endocrine or neurological disorders, pelvic surgery, radiotherapy, or trauma, damaging innervation and blood supply to the pelvis and penis. Drug history should be required. Inquire about current medications and ED treatment already tried. Social history should be asked. Smoking, alcohol consumption. Full physical examination should be done. Cardiovascular system, abdomen, neurological examination. Digital rectal examination to assess the prostate. External genitalia assessment to document foreskin phimosis and penile lesions like Peyronie's disease. We should confirm the presence, the size, the location of the testicle. The bulbocavernous reflex can be performed to test the integrity of spinal segments S2 to S4, and this is done by squeezing the glands, which will cause anal sphincter and bulbocavernosal muscle contraction. Investigations. Blood tests, fasting glucose, PSA, serum testosterone, sex hormone binding globulin, LH, FSH, prolactin, thyroid function test, fasting lipid profile, all should be done. Nocturnal penile Thomason's testing. We call it Regiscan device. This contains two rings, which are placed around the base and distal penile shaft to measure the Thomasons, the number, the duration, and rigidity of nocturnal erections. This will be illustrated in the next slide. Color Doppler ultrasound measures the arterial peak systolic and diastolic velocities, pre- and post-intracavernosal injection of prostaglandins. Illustrations here showing the use of Regiscan and applying the bulbocavernous reflux test. Causes of erectile dysfunction, impotence. I inflammatory, prostatitis, mechanical, M, Peyronie's disease. Psychological, depression and anxiety, relationship difficulties, lack of attraction, stress. Occlusive factors, including the arteriogenic, hypertension, smoking, hyperlipidemia, diabetes, peripheral vascular disease, while venogenic include impairment of veno-occlusive mechanisms due to anatomical or degenerative changes. T attributes to trauma, pelvic fracture, spinal cord injury, penile trauma. Extra factors, like iatrogenic factors, for example, surgery, prostatectomy. Others, increasing age, chronic renal failure, cirrhosis. Neurogenic CNS causes, like multiple sclerosis, Parkinson's disease, multisystemic atrophy, tumors. Spinal cord causes, spina bifida, multiple sclerosis, syringomedia, tumor. PNS, peripheral nervous system, pelvic surgery or radiotherapy, peripheral neuropathy, and diabetes or alcohol related. Well, let's show you a list of the drugs that causes impotence. Chemical antihypertensives like beta blockers, thiazides, AC inhibitors, antiarrhythmics like amiodarone, antidepressants, tricyclic antidepressants, the monoamine oxidase inhibitors, the selective serotonin reuptake inhibitors, anxiolytics like benzodiazepine, anti-androgens like finasteride or cyproterone acetate, LHRH analogs, anticonvulsants, phenytoin, carbamazepine, anti-Parkinson drugs like levodopa, statins like atorvastatin, alcohol, all can contribute to erectile dysfunction. Treatment. Psychosexual therapy aims to understand and address the underlying psychological issues and provide information and treatment in the form of sex education, instruction on improving partner communication skills. Cognitive therapy and behavioral therapy, programmed relearning of couples' sexual relationship, and also, of course, this is a duty of the psychologist. Oral medication, phosphodiesterase type 5 inhibitors, PDE inhibitors, sildenafil, Viagra, tadalafil, Cialis, vardenafil, Levitra. PDE inhibitors enhance cavernosal smooth muscle relaxation and erection by blocking the breakdown of cyclic GMP. Sexual stimulus is still required to initiate events. Side effects include headache, flushing, visual disturbance. Contraindications: patient taking nitrates, recent myocardial infarction, recent stroke, hypotension, and unstable angina. Androgen replacement therapy. Testosterone replacement is indicated for hypogonadism. It is available in oral, intramuscular, pellet, patch, and gel forms. In older men, it is recommended that PSA should be checked. Intraurethral therapy. We use alprostadil, synthetic prostaglandin, pellet administered into the urethra via a specialized applicator. Once inserted, the penis is gently rolled to encourage the pellet to be dissolved inside the urethral mucosa, from where it enters the corpora. Side effects include penile pain, priapism, local reactions. Intracavernosal therapy. Alprostadil, Cavorget, synthetic prostaglandin, papaverine smooth muscle relaxant, plus minus phentolamine, which is an alpha adrenoreceptor agonist. Vacuum erection device. Penile prosthesis. They are semi-rigid, malleable, and inflatable penile prostheses and available for surgical implantation into the corpora to provide penile rigidity and sufficient erectile size for sexual intercourse. Side effects include mechanical failure, erosion, and infection. The second slide is an illustration of penile prosthesis device.